Well, thanks again for everyone for coming. We had some very interesting talks so far. I'd like to talk a bit about postoperative endophthalmitis. So we're going to talk about the typical course of excessive postoperative inflammation, talk about the EVS a bit, and management of endophthalmitis. So when we look at patients with exaggerated, prolonged, delayed postoperative inflammation, it's helpful to kind of group them into these three camps. There are patients who, within the first couple of days, have a profound and severe inflammation. There's another group that, more commonly, patients with endophthalmitis would fall into this group, but they would, within the first 2 to 7 days, but up to 14 days, would develop a progressive increase in their inflammation. And then there's the delayed inflammation group who oftentimes they improve a bit right after surgery with respect to their inflammation. And then there's either a precipitous or gradual rise in inflammation after that. So some of the things we're looking at these patients, not just for diagnosis, but also for treatment. So it's very helpful, as Dr. Duker mentioned, to do a gonioscopy if there's excessive inflammation. You really want to see if there are any lens fragments, if there are any suggestion of something that went wrong in the cataract surgery that we might not otherwise know at that point. There's vitreous to the wound. Either any of these things, if it is endophthalmitis, might change our timing or plan for possible vitrectomy. And it just helps for deciding whether or not they're infected at all. So wound integrity is very important. It's important to do Seidel testing in all these patients. For chronic patients, looking at IOL deposits, doing a B scan in patients with poor view to see if there's choroidal detachments, retinal detachments, lens fragments posteriorly, or anything else interesting. So in the group of patients who have profound immediate inflammation, you can have an endophthalmitis from anything, any type of organism if you have a large enough inoculum early on. But commonly these are virulent organisms like Pseudomonas and strep, sometimes Staph aureus. Complicated surgery can do this, and we'll talk about toxic anterior segment syndrome a little bit in just a second. This has been talked about more frequently over the past decade or so. 2 to 14 days, endophthalmitis from any organism really. Retained lens material can cause that as well. We know patients with severe levels of diabetic retinopathy have compromised vasculature, and they're much more likely to have a prolonged or excessive exudative response after smaller insults or less inflammation than other patients might have, and uveitic patients, of course, as well. When you have inflammation that starts much later, you also have to consider the fact whether there is a wound manipulation somehow and there's a late inoculation, but also other organisms like P. acnes, fungal organisms, less common organisms like mycobacteria, bleb. If they have a bleb, of course, you can have bleb-associated infections as well as several other causes that we keep in mind. With TAS, it's a very specific constellation of findings where within the first 24 hours, typically, patients have profound limbus to limbus corneal edema with excess fibrin. You can get a lot of fibrin, of course, in endophthalmitis, but TAS is very much, these patients are very commonly have a profound amount of fibrin. They have little to no vitreous cell. We like to, it's commonly said that these patients have a lot less redness and pain than do patients with endophthalmitis. But we have to remember from the EVS that a significant proportion of patients who do have culture-proven endophthalmitis have no redness or no pain. So it's fine if you're correct about TAS, but you just can't be wrong. I have one patient in particular that I'm thinking of that was managed just with steroids for a week or so. He ended up being enucleated for presumed diagnosis of TAS. There's another patient as well who ended up no light perception. It's tough to say what would have happened otherwise, but the point is you got to be right if you're going to treat someone as TAS. So early on, if you see someone with new symptoms and they have no inflammation in their eye, there are a couple of findings that have been shown to be associated with the beginnings of endophthalmitis, and this is important to recognize. So it was reported a while ago that retinal paraphlebitis can be associated with early endophthalmitis. But I'm also aware of a couple of cases, one patient after intravitreal injection presented the next day with significant pain and had diffuse retinal hemorrhages, but there was no inflammation at all that was reported. The retina specialist was very good and looked very carefully. However, the next morning, the patient presented with an eye that was full of pus, and they ended up losing their eye. There's another case as well that I was made aware of after vitrectomy with a similar pattern, so it's something to keep in mind. As far as an evidence basis for endophthalmitis, we really looked at the endophthalmitis vitrectomy study. What the study did, and we all know the study, but it took 420 patients, put them into 4 groups, looked at vitrectomy versus tap and inject for management, also looked at whether or not systemic IV antibiotics and hospitalization was helpful in these patients. And the patients were usually between 20/50 and light perception, and these are all patients within 6 weeks of either cataract surgery or secondary lens implant. In order to be enrolled, you had to have a cornea and anterior media that was conducive to performing a vitrectomy, should that be where you were randomized. So the patients who did undergo vitrectomy, after an undiluted sample, they would take a small amount of the central vitreous. You had to get more than 50% of the vitreous, but it was strictly recommended not to create a posterior vitreous separation. So this is a very conservative vitrectomy. The tap and inject arm, we should put that in quotes. What the patients, the investigators had the option of either taking a needle aspiration or doing a one-port vitrectomy. And if you did a needle aspiration and you didn't get a sample, you had to do the one-port vitrectomy, and you took a small vitreous sample. The IV antibiotics were ceftazidime and amikacin, which are not known to particularly penetrate the eye well. There were standard medications, including intravitreal amikacin and vancomycin, subconjunctival medications, including steroid, topical medications that were more or less frequent, based on whether or not there was a wound leak, and then oral prednisone for 5 to 10 days. So what did the EVS show? First and foremost, the primary conclusion is if you have worse than hand motions vision, you benefit from a vitrectomy. These patients here, if you look at the patients who are light perception only, 32% ended up 20/40 or better if they had a vitrectomy, whereas only 10% if they had to tap and inject. If you go down the line for 20/100 or better or 5/200 or better, there's a significant advantage for the vitrectomy group. We also found out that ceftazidime and amikacin IV were not helpful. So when we look at these conclusions, the critical detail is the vision. So how do you determine whether or not someone has hand motions vision? Well, it's not just waving the hands in front of the face, which we do sometimes to test vision, but you can just have an obscuration of the light, and it really could be light perception by the EVS criteria. So what they did is 2 feet in front of the face, they would hold the hand and go back and forth, up and down, or keep it still with some backlighting. The patient had to identify that 4 out of 5 times, and that's important because we don't want to overestimate someone's vision and say their hand motion and keep them from the vitrectomy that would be helpful for them. So staph epi, coag-negative staph endophthalmitis was most common, nearly always sensitive to vancomycin. More concerning are the non-staph epi types of endophthalmitis, Staph aureus, streptococci, and gram-negatives, and these are more common in injection and blood-related endophthalmitis. The risk factors in the EVS for having a non-staph epi infection were symptoms within 2 days, corneal infiltrate, wound abnormalities, light perception vision, APD, and also loss of red reflex, so if they have significant medial opacity. When we look at the breakdown of the infections, these are the culture-positive cases. As we said, coag-negative micrococci are here. That group did very well, 84% by endophthalmitis standards. 84% were better than 2100, whereas the other groups did not fare as well. In a post hoc analysis from the EVS, though, when they looked at the infecting microorganisms and compared it to the vision and presentation, it was still more powerful in predicting the visual outcome and the favorable response, whether or not the vision was severely affected. So we know that these are very predictive which bug infected the eye, but the vision is still the important thing here. We also learned that in addition to patients not having redness and pain on occasion, 14% didn't have a hypopion. We also learned that when you do a conservative vitrectomy, you don't have an increased risk of retinal detachment in comparison to the tap and inject group. And furthermore, the tap and inject group from the needle doing the tap and inject versus a single port vitrectomy, they were about the same. And all these were in the 8 to 11% range, which is quite high, but they were similar between the groups. There's a question whether diabetics were more likely to have endophthalmitis because 13.8% of the patients in EVS were diabetic. They had worse outcomes somewhat compared to those who are not diabetic. And there's also a trend towards improved outcomes with vitrectomy if their vision was better than light perception. This wasn't statistically significant. It's difficult to know exactly what to make of it, but keeping it in mind with some of these diabetic patients, if you're on the borderline, it may be helpful to consider vitrectomy sooner. So as far as what's changed since then, since the mid-90s, well, we have a better awareness of the toxicity of the intravitreal amikacin. We knew the other aminoglycosides were problematic, but amikacin can cause retinal toxicity as well. And there are other new medications, such as particularly moxifloxacin, we'll talk about in a bit, and they're improved vitrectomy techniques. It's likely that the wide-angle viewing and the small-gauge vitrectomy are a bit helpful in this situation, but the effect on the results is still remains to be shown. So overall, there's minimal new pivotal data, but there's significant interpractice variability. So we've shifted a bit towards ceftazidime for intravitreal therapy. We have some other antibiotics that we inject more commonly in the eye than what we used to with new comfort level. But we always use vancomycin. It's nearly 100% active against gram-positives. Moxifloxacin is interesting in that it's a bactericidal fluoroquinolone that penetrates very well, good gram-negative and gram-positive coverage. It's not clear, however, that any systemic therapy has a benefit over the intravitreal administration of these drugs at such high levels. There's the question of the RD risk that I question whether that's a true independent risk factor, but it's something to pay attention to. We know that in some patients, you can have a uveitis or a pigment release stimulated from moxifloxacin. At this point, I don't typically use it, but there's some situations if someone's distant and they can't get in for hours and hours, but they have access to moxifloxacin before tap and inject maybe. It's something to keep in mind, and we're still defining the role. So corticosteroids, we're shifting a bit away from systemic steroids and more likely to use intravitreal dexamethasone and subconjunctival. Topical antibiotics, there's a bit of a shift towards moxifloxacin, but in some patients who have a wound leak or bleb-related endophthalmitis, we might still consider topicals, or if there's a corneal ulcer. Ferenc Kuhn and some of his associates proposed doing early and complete vitrectomy for some of these patients, and this is new since the EVS. What they used for their criteria to identify patients to do vitrectomy with endophthalmitis is if there were no visible retinal details or if they didn't have any improvement within the first day or so after a tap and inject. The other thing that they did differently is they lifted the posterior hyaloid. So commonly in these cases, you have a posterior vitreous attachment, and they would go and carefully separate it off the nerve. They wouldn't lift it into the anterior periphery. They would just trim it short in the mid and anterior periphery. And then sometimes you see this cottage cheesy just coagulum of junk over the macula, and they would vacuum that up meticulously. The thought being that there are cytokines, that there are toxins, there are a variety of problematic chemicals that they could remove doing it that way. And of course, you can't compare clinical trials from one to another, much less a consecutive series to a clinical trial, but they had very good outcomes. 91% had better than 20/40 vision, and there were no retinal detachments in that series. It might have been the 48th eye, but even then, that's still a pretty low rate. So when you compare that to the EVS results, even if you look at the patients with the best vision in the EVS, they still only had 75, 78% better than 20/40. When you look down at the patients who didn't have a red reflex in the EVS, it was only 0.05, but there was an improvement in these patients with vitrectomy over tap and inject. And it's likely that there are some patients who are a bit better than this arbitrary cutoff of hand motion versus LP that might still benefit. So if the media opacity is profound, it's something to consider. The other question is, now we have better endoscopic capabilities for these vitrectomies, or at least at some sites we do. And the question is, for some patients with corneal opacification, would they do better getting the vitrectomy that they wouldn't have been able to get before endoscopy? That's not clear. That still needs to be defined. One point on anesthesia, you really need to anesthetize patients well. The most angry patient I've ever seen in my life was a guy who came in the day after receiving a tap and inject with topical anesthesia the night before in the ER by someone else. And it is extremely, extremely unhappy. Point being, you got to consider subconj anesthesia or even retrobulbar for some of these patients. It hurts. So if you have a dry vitreous tap, you have the option of doing just an AC tap only or an intractor or no tap at all. We know that the vision's the most important predictor, but it's still nice to get a tap. I usually get an AC tap, but I'm not vigorous about going after a vitreous tap over and over by any means. A couple other notes. If you have chronic endophthalmitis, you definitely want to do fungal cultures. We know that. One other tidbit is if you suspect mycobacterial infection, you really have to make this known to the lab. And if you're inoculating the material yourself, you can consider doing two slant, either Lowenstein-Jensen, or we use a 7H10 slant, because they can incubate these at a couple different temperatures, and it's more likely that you're going to get a positive culture. So the question is, for some of these more chronic cases, when should you consider explanting an IOL? I'd advocate explanting them always in mycobacterial infections, and most of the time in fungal infections too. With P. acnes, it's up in the air. Some people do it either way, but commonly, if at least debulking, or you can try vancomycin first, but many of these lenses and materials have to come out as well. This is a patient with mycobacterial endophthalmitis. We explanted the lens, and we found here, this is the previous patient here, found down in his Sommering's ring, he had some acid-fast bacilli sort of hiding in a cleft there. He had had a series of amikacin injections elsewhere, and the infection would keep coming back. After explanting the lens and putting on oral clarithromycin, he's been doing well for a year and has very good vision. Mike Stewart in Jacksonville, Mayo, had the first case of someone with very good vision after mycobacterial endophthalmitis. They were 20/20, and he used that combination as well in addition to linazolid. But this patient couldn't tolerate linazolid, and they did well like this too. So there are other types of post-op endophthalmitis, injection-related, bleb-related, more likely to have strep species and other bad bugs, gram-negatives and bleb-related. We have the benefit of taking the EVS, and when we want to do the vitrectomy, we can say we're following EVS and do it. And when you don't want to, you can say, well, this doesn't meet the criteria because this is not a post-cataract condition. But I do think it's important to consider the fact that given that the vision was shown to be the most important predicting factor, to still consider vitrectomy for the patients in similar situations, some of these types of endophthalmitis. Post-vitrectomy endophthalmitis, some similar types of bugs, mostly gram-positives. Post-traumatic is a different species. You have to consider empiric antifungal treatment. Endogenous, you consider vitrectomy. That's a whole talk in and of itself. But I just wanted to go over a few of these thoughts on endophthalmitis, and thank everyone again for coming. Appreciate it.